We'll get started. So thank you all for joining us tonight. Tonight in the UK, this afternoon in the US, from where our speaker is sitting. My name is Justin Parkhurst. I am an associate professor of global health policy in the Department of Health Policy. I'm also the current sitting chair of the LSE Global Health Initiative, which is a interdepartmental research unit that tries to organize and raise the profile of global health related work across the LSE. That said, this talk tonight is not being organized by us, but is organized by the LSE Student Union Health Society. So thank you very much to the Health Society for inviting our speaker and for asking me to chair the event. I will very briefly introduce our speaker, Ambassador Jimmy Kolker, who is joining us online from the United States. Ambassador Kolker retired in January 2017 as Assistant Secretary for Global Affairs at the US Department of Health and Human Services. Ambassador Kolker has a 30-year diplomatic career where he served as US Ambassador to Burkina Faso and to Uganda. He was Deputy Global AIDS Coordinator in the Office of the US Global AIDS Coordinator, leading the implementation of the President's Emergency Plan for AIDS Relief, which some of you may know better by its acronym PEPFAR. Ambassador Kolker was also Deputy Chief of Mission at US embassies in Denmark and Botswana, and has won awards for political reporting at earlier posts in the UK, Sweden, Zimbabwe, and Mozambique. He's an engaged advocate for health and science diplomacy, and that's what he's going to be talking about with us today. His topic is where global health and public policy intersect, a diplomat's perspective. So, Ambassador Kolker, thank you so much for joining us. I will hand over to you.
Well, thanks, Justin, and thanks to Hugo and Bridget and the LSE Student Union Health Society for the invitation. I am going to use slides, and I'll try to go through them quickly, although there is a lot of text, but to leave plenty of time for comments and questions. This is a list of the topics I intend to cover, and I will go through them fast, but I'm going to give some examples from my experience as a health diplomat. And I should just warn you all by saying that I never took a science course at university, so I am not a medical professional or someone that has an academic credential to do what I do at all. But I did discover a number of opportunities where diplomats could add value to public health goals and vice versa, where health issues could make diplomatic collaboration and bilateral and multilateral diplomacy succeed better. But first, there really are two cultures, and the idea that scientists, if you see evidence and it's consistent or there's an anomaly, you do further research, and if the evidence is strong enough, you publish your results in a peer-reviewed journal and you've solved the problem. But of course, diplomats don't read peer-reviewed journals, and if we're good at our jobs, and some of us are, we put our priorities on other people's agendas. And it's worth looking at all of those words individually. First of all, not everything scientists do is a priority in terms of policy, but also who are these other people and what are their agendas? And if you're working in diplomacy, for instance, you're often talking about leaders of other governments, and to put our priorities onto their agenda is something that requires diplomatic skills, and you need to package and communicate the data and evidence in a way that's accessible to non-scientists. And at the same time, we as diplomats need to understand how we access and incorporate that data into our decisions and our policy priorities. The data rarely speaks for itself. And there also is a historic paradigm, which really is last century, but this is the way many people think about global health. And I'm sure those of you who are working on the joint program or who are connected to background in health policy realize that the traditional model talked about donors and recipients of foreign aid. And these programs would provide a proof of concept or a pilot study or a center of excellence in a recipient country. And the medical professionals, program managers from developed countries would come and actually provide services to local people, almost always for infectious diseases. And there was a similar pattern in researchers. Researchers from developed countries would get grants and would find local research partners in developing countries, but these were not necessarily priorities identified by the countries in which the research was taking place. Fortunately, we have a new paradigm, which is that is, I think the audience for this talk represents. Virtually every low and middle income country now has a critical mass of qualified nationals who have every bit the academic expertise that the providers of previous foreign aid had coming from high-income countries. But what low and middle-income countries, in my experience, want is a kind of partnership or community of practice to bring their own systems up to first world standards. So they are respectful of the technical support that another system, for instance, the United States or in Europe, can provide, but that it's not because they want that service provided for them so that they can improve the quality and access in their own countries. And there's a parallel track in research institutions that there are many very strong universities now in Africa, Asia, Latin America that are identifying their own research priorities and do want partners from other parts of the world to help them with their research, but they want to be in control of setting those priorities and looking at how the results might be used. And this coincides with the changing disease burden, whereas 30, 40 years ago, it was certainly true that communicable diseases were responsible for morbidity and mortality in almost in 2/3 of the countries in the world. That now has dramatically changed so that it's chronic and non-communicable diseases in almost every country in the world, with a little bit of an exception for COVID. But the trend is certainly that it is not communicable diseases, which are the real heavy burden of disease and certainly not a cause of death. There's a requirement for national ownership. You want a national strategy, you want a national coherence to the health response. And of course, COVID has reminded us, which we should have known before, but didn't, that preparing for outbreaks and even for bioterrorism need to be part of a national health strategy. So my experience, as I said, was that I was ambassador to Uganda 2002 to 2005 when the president's emergency plan for AIDS relief was developed. And by that time, there was a 3-drug combination antiretroviral therapy that worked and had been since 1996 routinely administered in high-income countries. Many of the people who took those drugs, although it did prevent the acceleration of HIV into AIDS or to opportunistic infections because of compromised immune system, there were many side effects, and the drugs were considered so toxic that they were administered only under strict medical supervision of specialists. They were very expensive. They required quarterly viral load tests, which were also expensive and high tech. And of course, there were no studies of long-term outcomes. If this had been a traditional drug development, you would have looked to see, well, 5, 10 years from now, how has this cohort survived? Are there long-term impacts that we're not aware of? Naturally, that was not the case of a drug that had only been prescribed as standard of care within the last 5 years. But the diplomatic challenge in Uganda was uncertainty. Every article in these peer-reviewed journals starts with uncertainty and ends with more research needs to be done. But if you're a policymaker and your mandate is to put everyone in Uganda who qualifies for treatment on these antiretrovirals, the idea that there's uncertainty and that more research needs to be done are huge impediments. You need to make a now or never decision. Are we going to carry out this program? And there certainly were risks. There were risks to the patients, but there were also risks to the reputation of the United States as being responsible for prescribing very strong drugs to people who were in isolated locations. Many had stopped cultivating or were undernourished. There were almost no AIDS specialist doctors. There certainly were very few trained doctors and nurses who could monitor patients all over the country. We thought at the time that you needed to take pills at precise times, and that there was an accusation, at least not true, but accusation that people in Africa might not be able to adhere to that regimen. How would you monitor side effects or treatment failure? And how would you pay for this? No government except Botswana at the time was actually providing these drugs. But just in Uganda alone, there were more than 50,000 HIV positive people. All they needed was money. They were in care. They just needed the treatment. So of course, we did decide to go ahead with scaling up to try to reach everyone in Uganda who needed help. And miraculously, our fears were not only not realized, but the Ugandan patients were superior to American patients in complying with the regimen. The paraprofessional follow-up, often high school graduates on motorcycles who were visiting the people on treatment every week or two, were able, through proxy indicators such as headache, nausea, other common side effects, to identify problems and bring them in for more professional treatment. And it turned out that patients were metabolizing, when you started on the antiretroviral therapy, metabolism increased so fast that they were actually metabolizing faster than a person who was not ill and on treatment. And therefore, hunger was what the patients complained about most. It wasn't that the drugs didn't work, but they were hungry and couldn't satisfy their appetite. And so the enrollment, we also were able to scale up at least as fast as we had hoped for and much faster than we expected. So the results in Uganda were just remarkable. And almost everyone in Uganda by 2005, when I left the country, knew of someone whose condition was improved dramatically by the access to antiretroviral treatments. And it was a tremendous boost for US relations with Uganda at the time. Moving quickly, though, to Ebola. This is a map, of course, of Guinea, Sierra Leone, and Liberia. The original outbreak, I don't know if you can see my arrow on your screen, but was in Gekadu, which is in the very middle of the zone forestière of Guinea. And as you can see, it's far from the capital, Conakry, very difficult to reach, but also in a border area of Sierra Leone and Liberia, also far from the capital. And the red areas were the ones where the Ebola incidence was the highest. In fact, these were not only remote areas, but they were opposition strongholds in all three countries with profound mistrust of the central government, and where the institutions and infrastructure had been severely neglected over decades. And so these were all incentives for underreporting. The government didn't want to admit that it wasn't aware of what was going on in some parts of the country, had a false sense that our health systems are capable of doing all this. Certainly there would be penalties in terms of trade, tourism, and restrictions put on countries where there was an outbreak of a fatal disease like Ebola, and that did happen. And then the World Health Organization was at the time organized with a very weak region in Africa, which had as country directors for WHO in the three countries, people who were enabling rather than challenging the public health denial of the three governments. So WHO, which should have been our watchdog in those countries and reporting out what was actually happening, became an enabler of this underreporting and a false sense of confidence and bravado that this was under control. So just a side note for a moment about the World Health Organization. So many of you know it was the first UN technical agency, but its model, if you can imagine, is that it's run by a week-long assembly of ministers of health who work on a consensus basis. So if you think about that, 190 politicians who all have to go back and account for what they've been doing in Geneva for a week. And so it means that most of the resolutions passed and decisions made are kind of least common denominator that anyone can agree to, but may not have much punch in terms of implementation. And the leadership of WHO, the Director General, is elected by a one nation, one vote system, which means that the DG is deferential to member states, was certainly deferential to China at the outbreak of COVID, but was very deferential to Guinea, Liberia, and Sierra Leone during the Ebola outbreak, countries that didn't have nearly the global impact that China or the US does. WHO is routinely very deferential and considerate of what US views and not wanting to disagree publicly. But the idea that WHO looks to member states and doesn't disagree with them unless it's absolutely forced to is an important aspect to remember in this multilateral organization. And so the collaboration required in the Ebola response was the three offices listed on the slide, none of which was especially dynamic or well led at the time. And they do have an obligation to declare the public health emergency of international concern, but they do this by convening independent experts, and they really do not have a mandate to look for information outside of that supplied by the member state governments. So they've been perpetually behind the curve in recognizing the seriousness of the impacts and of declaring these public health emergencies, both in Ebola situation and in COVID. And one thing that's really important is that they provide normative guidance and technical support. They can mobilize resources from others, but WHO does not provide patient care. And that it doesn't actually provide health services in countries. And that, of course, means that it's up to other partners or the government itself to provide those. So with the failure of this global health governance, the WHO not being able to rise to the occasion, either regionally or through its Geneva activities, there was the strong desire, and I was part of those meetings when I was at the Department of Health and Human Services in charge of international affairs for our Ministry of Health, that President Obama himself said, well, this is in the European time zone. Why aren't the European countries taking leadership here? The US interests really were hard to define. These were not countries of great strategic priority. There were almost no direct flights, very few travelers arriving in the US coming from those countries. We did not already have Centers for Disease Control presence. USAID was only involved in malaria. And so the question is, well, why is this our problem? Who owns this problem of Ebola in West Africa? And in the end, Tom Frieden, the head of Centers for Disease Control, presented it to the president as, this is out of control and no one else is going to be willing or able to step up. The US has to take the lead to do this. And that was persuasive, and we did, but in a peculiar way. And this is where the diplomacy comes in. In order to provide treatment centers nationwide, the US military had the logistical capacity to bring treatment, essentially large tents and some equipment that could be rural treatment centers, but they couldn't staff these treatment centers. This was up to the Liberian government, but especially USAID and other donors contracting with non-government organizations to staff the clinics. But in order to staff those clinics with people from outside of Liberia, many of them Africans, but many of them also from other parts of the world, they needed to have some assurance that if they were infected with Ebola, that they would get first world quality treatment. And so that deal was that the US in Liberia, the British in Sierra Leone, the French in Guinea would provide a hospital that would be for treatment of health workers. And so we hadn't done this before, but it fell to the US Public Health Service, a uniformed service, but which has about 6,000 members, but all of whom have other jobs. They provide Indian healthcare, prison health services in the US, number of researchers and people in various government departments. But none of them were immediately available to go without backfills in their current jobs. None of them were licensed to practice medicine or prescribe drugs in Liberia. None of them were Ebola specialists who, what would be the standard of care? Would they simply try to bring the electrolyte levels of patients up, or would they actually try to put them on oxygen machines? Where would they get trained for that? And then who would provide the security for this facility? As you remember, there were attacks on healthcare workers during Ebola in Liberia and other countries. Where would they be housed? How would they get clean water to the facility? How would they have transportation? And who would have access to the facility? What's actually the definition of a health worker in this context? These are all problems which, it turns out, have not medical so much as diplomatic solutions. And what we learned is that we send out an advertisement on a Friday, and by Tuesday, 1,000 of the 6,000 Commissioned Corps people had volunteered for 6-week deployments. We did get from the US Department of Defense and Centers for Disease Control priority access to training for these people who would staff the field hospital in Monrovia. But it was the US Embassy in Monrovia that had to address where would this field hospital be located, where would the staff live, how would they get permission to actually practice medicine in Liberia, and who would have access to that care, and how would this fit into other things that were going on in Liberia. The very good news, and I did visit Liberia after this facility was established. I wasn't there when the epidemic was at its height, but virtually everyone we talked to said that the idea that the Americans and the US military were coming were in itself a factor in changing the behavior of Liberians, that this was not something that was inevitable or from the ancestors or imposed on someone for bad acts, but this was actually a biomedical condition for which there was going to be more hope of survival, and that there were ways of prevention, which Liberians, in terms of cleaning their hands, of not embracing, not shaking hands, how they buried their dead, how they interacted with a potential patient, changed even before that field hospital was established, because of the idea that we're now in the solution phase of this crisis. Sierra Leone, and especially Guinea, did not have a comparable sort of all systems mobilized approach, and there was no comparable behavior change. And if you remember, Ebola took much longer to eliminate there, almost a year longer in the case of Guinea than it did in Liberia. And even though the treatment unit began only in November 2014, after the surge had essentially ended in Liberia, and only treated less than 100 patients, they did have a very high survival rate, and the operation was a success more by its conception than by its actual execution. But it did turn out that this could be done, and these practical and diplomatic problems of how do you deal with a public health emergency in a country where we have none of the preconditions have been met for actually practicing medicine. How do we deal with that kind of situation? So I'll pause for a moment to say this was the legacy that at least American decision makers had when COVID was discovered. That in Liberia and in Guinea and Sierra Leone and in neighboring countries, there had been USAID disaster assistance response teams. CDC had the surge capacity. Those had largely worked. At least we thought they did, and there was satisfaction that this had been an effective intervention. There also was considerable research that had gone on, and both the National Institutes of Health and the Public Health Service, the people who ended up staffing the clinic, the national clinic, did their jobs. There were volunteers who did a good job in the rural treatment centers. And the US military, although it was very limited logistical support, did provide timely support. So there was a good feeling about this. But what we didn't factor in was that US domestic preparedness was never tested. There was a lot of preparedness for Ebola, but there were actually only 2 people who contracted Ebola in the United States of America. And so we were looking at how to reform institutions that would deal with other parts of the world. And I was involved very directly in the WHO reform, which merged the 2 divisions which were competing for attention and resources into a single health emergencies response. They did very well in the 2018 DRC Ebola outbreak, but there was no sustained political attention to health security. The UN Security Council never met again after they met about Ebola. And some of the G7 commitment of money, an organization that of a kind of coalition of the willing called Global Health Security Agenda, that raised money for outbreak preparedness. They both made some progress, but there was no political motivation behind really scaling up. So in 2019, when COVID hit, we were ready to fight the previous war. It turned out that wasn't going to help us very much. And then another slight diversion, but setting the stage for COVID, was Zika. If you remember, this was in Brazil, was a strange virus that resulted in in birth defects, and that had not been experienced before, although the virus had been around for a long time, named after a forest in Uganda where it was first discovered. But the results in Brazil were much more frightening than they had been in any previous outbreak. And of course, this being Brazil, the president of Brazil on February 1st of 2016 called President Obama and said, of course, we're Brazilian, so we're doing everything perfectly. But just in case, would you mind sending some experts down here to kind of be sure to talk through what we're doing? And the US had a lot of incentive to do that, because the Brazilians, for political reasons, were not responding to our requests, for instance, for sample sharing, which we needed for blood safety measures. There were proposals for vaccine development based on dengue and chikungunya vaccine candidates, which we thought would be effective, but needed field study and so on. And CDC had a lot of expertise in birth defects and wanted to do some cohort studies in northeastern Brazil. All of these were being held up for political reasons by the Brazilian Ministry of Health. So 2 weeks later, I led a delegation of our 12 best experts to Brasilia, and we talked this all through and came up with a matrix of issues on which Brazilian parastatals and US agency leads were named, and then we signed a document by the Minister of Health was the co-signer to give kind of political permission for these technical collaborations to take place. So by having a US-Brazil collaboration framework at the diplomatic level, it facilitated and gave cover to the technical people to do what they would naturally do anyway, but were worried about political repercussions. And this was especially relevant because the Brazilian government, as many of you remember, fell 2 weeks later. And so there was, in fact, no real continuity in government in Brazil, but this collaboration framework stood that test of time, and the technical collaboration continued largely uninterrupted for the Zika response. So what does this mean for COVID and China? In 2003, the severe acute respiratory syndrome, SARS, killed a number of people, was very fatal, but did not spread as widely as people feared. But the Chinese were quite spooked by this, and they established a CDC on the US CDC model very consciously, with US CDC staff embedded in the Chinese CDC model. There was collaboration around in 2013 when there was a bird flu outbreak, which people thought could become a pandemic. It did not. It was controlled because US and Chinese surveillance people worked together to do that. The US and Chinese worked together in Liberia, worked on the Africa CDC. But most important, there were 3 bilateral agreements for sharing information. Just like in Brazil, there were agreements that gave technical people permission to share. This is even more important in China than in Brazil, that if you're a Chinese scientist, you need to cite scripture in order to share information about X with Y. And if Y is the United States, you especially need permission, that you have covered, you say, this is part of our official collaboration. And so up until 2016, the US wasn't dependent on Chinese official statements or the World Health Organization for information about outbreaks. We had separate bilateral communication. But starting before the election of Donald Trump, CDC was under pressure to move out of the Chinese CDC complex, which was an hour from the capital, and into the embassy compound because of fallout from the deaths in Benghazi, when the security of American personnel was paramount, and the functionality of being at the Chinese CDC headquarters was discounted. I dragged my feet on doing this, but by 2017, when President Trump was elected, there was a requirement to reduce our footprint in China, and the CDC staff went from 47 to 14, majority being Chinese nationals. There were only 3 Americans in CDC in China when COVID started, and all of them were moved to the embassy compound. And then it was not true for CDC, but we also had Food and Drug Administration, National Institute of Health staff in China in 2020. But when the embassy was evacuated or drawn down because of COVID, all of those other health professionals were moved to Bethesda, Maryland, 12 time zones away, in what was really a self-defeating sense of disarmament in our health response within China. And perhaps even more severe, we let all 3 of these enabling agreements, including some binding ones, including ones specifically about emerging infections, all of those expired before or at the beginning of the COVID outbreak. So these agreements, which authorized and therefore encouraged Chinese technical people to share information with foreigners, with Americans, were no longer in place, and so they didn't have that cover. And we can say, well, nobody saw this coming, and indeed we treated a pandemic a little bit like an asteroid hitting Earth. There's a 5% chance between now and 2095 that an asteroid will hit the Earth and destroy life as we know it, but I doubt that any of you, when you saw your families or the people you're living with today, so what are we going to do if the asteroid hits today? It's just not something we worry about. We pay a few people to monitor outer space to see what the threat might be, but it's not part of our daily lives. And that's how we were thinking about outbreaks and epidemics. We'll pay some experts to follow it, but we don't really have to worry about it. It's not going to happen to us. The the metaphor we should have been using is terrorism. On average, before 2020, terrorists killed a couple tens of thousands of people worldwide per year. Almost all were in the Middle East, Africa, or South Asia, so Americans, Brits didn't worry too much about it. But yet, 42% of Americans said they were worried or very worried about themselves or a family member being a victim of a terrorist attack. Disease outbreaks were just remarkably similar to that. There are over 100 significant outbreaks a year. The deaths are in the low tens of thousands. They're almost all in Middle East, Africa, or South Asia. But the appropriations for health preparedness were about 1/10 as much as they were for terrorism preparation and combating. So we didn't take the threat seriously, even though quantitatively we knew that we had a parallel which we should have been paying attention to as a benchmark. But the US was the best prepared country in the world. And those of you who are in the UK now would, on this global health security index, the UK scored number 2. Turned out we were not the best prepared for COVID. And if you look at the detail of the report, when you look at the left-hand column, I hope this is clear on your screens, that when you say exercising response plans, the US got 0. When COVID broke, the people who would actually be responsible for fighting COVID at a political level had never talked to each other about it before, even though there were plans in place, they had never exercised those plans. And if you look on the right-hand side, healthcare access, equity issues, the US was on a par with many African countries in absolutely failing scores, and we failed also in health capacity and in medical countermeasures and personnel deployment. So you could have foreseen what our vulnerabilities would be. We just didn't take them seriously enough, even in the so-called best prepared country in the world. So very quickly, we did have a strategy for outbreaks. This was post-Ebola, that there would be a task force chaired by the Secretary of Health and Human Services. Those of you who are in LSE or are working on international affairs and government policy realize that health ministries don't have mandates for economic and security issues. They have little knowledge of how the foreign affairs and security agencies work. They can't instruct embassies how to engage. They have to go through state or the White House to do so in the US system. And this task force lasted for only a week and was replaced by one in the White House, chaired by the vice president. But at the same time, the State Department Foreign Service role, the role of the people who should be engaging other countries in the response, was merely to evacuate citizens. They were specifically not authorized to look for public health cooperation during this early outbreak of COVID. The Biden administration kept the COVID coordination in the White House, Jeff Zients, now Ashish Jha, but focused really almost exclusively on domestic needs. And only when there were leftovers were these made available internationally, including vaccines. And so global health response has just never been in our political DNA to figure out, either by plan or by budget or by how we organize our response, to be a national security issue when it so clearly from COVID is. I'll go very quickly through these last slides since I'm really close to time, but just to say that this was a good, I think, an example of a good thing that diplomats and public policy people could do. Secretary Blinken convened foreign ministers for 4 different meetings, 3 of them virtual, on how can we get our governments to better communicate, to find some lanes of responsibilities, some timetables, some benchmarks, and some people in charge so that we can be accountable for the things that are listed on the screen. And about 40 governments from all over the world, Belize was a co-chair of one, Botswana was a co-chair, the India, Germany, Canada, Britain were all active in this global action plan. And they did have then some of the experts, but including both foreign ministry people and health ministry people working on questions that clearly span both realms, like governance and financing, like misinformation, and so on, and to try to get some accountable leadership and results from the international community. But in the meantime, the US government didn't do its part. We had asked for $22 billion. We were willing to settle for 15 in the last year's budget, and we got 0. And so there, in fact, is no new money for international global health or COVID cooperation dealing with pandemics and outbreaks. one word about vaccine diplomacy. There is no global vaccine development and distribution agency. And this is a problem because health is really a very national concern. And as we remember, the World Health Organization should be at the center of this, but they do norms and technical assistance, not healthcare, not procurement. And so we set up, in fact, without the US at the beginning, the ACT Accelerator with the vaccine arm is COVAX, and they had a model which actually will probably survive. The model itself was valid, which was that WHO, Gavi, and CEPI together got advanced market commitments in the billions of dollars, but they made two bad bets. They bet on the AstraZeneca vaccine and on the Serum Institute of India for 100% of the manufacturing of what they were paying for. And as you remember, the AstraZeneca vaccine turned out to be suboptimal, even though it had many advantages. But there was a better vaccine available, which the market rushed to. And the Serum Institute of India got, because of vaccine nationalism, was forbidden by the government of India from exporting all the vaccines for which the global community contracted. And I am speaking from a US perspective, but in the global health negotiations, it's really important to remember that the US is the historic guarantor of these rules-based, science-based orders and accounts for 50% of the investment in biomedical research. So to have a COVID response, especially in terms of vaccine development procurement, that didn't include the United States, meant that without some kind of informal cooperation, which frequently is the model that's used, that there's a WHO system and then there's a US parallel system, but they're actually synced. In this case, they were not synced, and it meant that there was a extreme vaccine nationalism. The highest bidders in a winner-take-all thing got first access, mRNA. The United Arab Emirates still has the highest vaccine coverage in the world. Qatar is very high. Israel is very high. Those three countries outbid everyone else for the early vaccines. US, Canada, others bid very high and got access to the vaccines early on. And the Russian and Chinese models, and it would have been great for the world if they had been as effective as the mRNA vaccines, but they had a much different model of having clinical trials with commercial responsibilities in those countries in which the trials were taking place, which proved not to be an effective model in this circumstance, and I think raised questions about how the Russian and Chinese approach to biomedical research and international collaboration fits into today's world in which there are these vaccine nationalism and winner-take-all markets. Finally, people talk about the global health architecture as though this was designed from a blueprint and carefully engineered, which we all know it wasn't. Well, it's a landscape. Maybe you didn't design it, but you can describe it, you can see it. But even that, it changes so fast that even that, I think, is inadequate. I think we have a global health governance traffic jam in which there are lots of people heading in a lot of different directions. Sort of normally on normal days, they get to where they're going more or less on time, but there's no bicycle lane, there's no express lane. And when you have a problem with getting something done quickly, the traffic jam just becomes gridlock. And the bicycle lane, there's nobody to actually get the solutions in real time to the most vulnerable people who are the hardest to reach. And we have all of these institutions, which we can talk more about one by one or together, all of which are part of this traffic jam, part of the solution. But the idea that where does the private sector fit in? Where does civil society fit in? Who's in charge? Is there somebody that actually can prioritize and assign responsibility, assign leadership, assign lanes? WHO certainly is eager to take over more of these, but through something called the Health Emergencies Preparedness and Response Blueprint, the HEPR. But member states have not gone along with this and do not see an obvious comparative advantage for WHO because it doesn't include the non-government actors, and because there's so many other organizations now that are not dependent on WHO for their own governance, their own funding, and their own priority setting. So this is a complicated slide, but here we are. If that's our granddaughter who's making noise, I apologize. Yeah.
I think that's a good 30-minute warning. So I know you wanted to me to about that point.
And I think this is my last slide because as many of you know, there is an intergovernmental negotiating body, INB, that's just had its 4th session in Geneva, trying to better prepare us for the next epidemic. And it's to design a convention, treaty, or other instrument by a year from May. And these are some of the areas in which they are considering what the trade-offs will be and whether you can get the unanimous consensus of 190 ministers of health in May 2024 for an international agreement, or whether that'll be ratified by countries like the United States is by no means a sure thing. Be quite a struggle. But this is where those of you who I hope are going to be devoting your careers to health diplomacy and trying to advance both diplomatic and public health goals, these are all issues that need to be addressed and focused much more coherently than they are right now. And we do have mechanisms to try to do that. And so your wisdom and energy and imagination in trying to reach these goals on sample sharing and sequencing, on reporting and information sharing, on equitable access, and on political leadership in particular, we really need some initiative and some innovation in all of those areas. And it's just a long slog right now, and the institutions are in a traffic jam rather than an architecture to try to meet that. I'll thank you. That's my email address if people want to follow up, but I'm looking forward to your questions, comments, and corrections from the presentation. I hope it stimulated some thought.
Okay, great. Well, thank you so much for that really interesting talk, covering a wealth of knowledge and experience from several really critical global health events, which I think many of our students are studying and really appreciate getting your firsthand knowledge of. I think we have probably 10, 15 minutes for questions. If lots of questions, Ambassador Kolker said he can stay on a little bit longer, but I'll ask if people online can write their questions in the Q&A function. That's usually the easiest way to manage them. But actually, we can probably have people ask verbally too. About 40 people still online. So if it's not overwhelming, we could have you raise a hand. And if so, then we can unmute you if you want to ask it directly rather than typing it. So would anyone like to raise any questions at this point?
I'll make one observation, which is that as we had tried to predict people's countries' preparedness for outbreaks, and as I said, there was absolutely no correlation between their ranking in this index of preparation and their actual success in early days of COVID. But there was a correlation, this has been documented by a guy named Tom Boyke here in Washington, among others, was trust in government. And those countries where there was a high level of trust in government and institutions and expertise routinely did better than those countries like, sadly, my own the United States, in which there was poor levels of trust between expert level, political level, and the people as a whole. So building trust in government has a huge public health benefit.
Okay, great. One hand's up now from Mara. Do you want to ask a question?
Yes, thank you for this incredibly interesting presentation. I covered a lot of topics. One question that came up for me that I've always wondered about in global health diplomacy is, how do you deal with, as a diplomat coming from a country with a certain value set, how do you deal with making policies and working on policies in countries where that value set is not met? You brought up the AIDS epidemic in Uganda, and obviously one group that is very heavily affected by HIV, men who have sex with men, which at the same time is a group that is not protected by law in Uganda. And I wonder how do you navigate those difficult conversations?
Right. It's one reason why I think generically involving diplomats in country in public health decisions is valuable for both sides, because certainly using a health-based approach to human well-being and looking at people who are vulnerable in that society, something diplomats need good science for. But at the same time, my time in Uganda, there were two excellent examples to prove your point. The representative at the time of UN AIDS, who was probably the leading multilateral person who was working on the topic, posted signs at Macquarie University. There were posters all over saying 4 o'clock Tuesday afternoon, meeting of people interested in AIDS and men who have sex with men. He was expelled from the country. And so that kind of approach turned out not to be successful in context. CDC, to my credit, to my admiration, they started without telling me because they were worried I'd turn off the program. They said, we're going to have a very behind the scenes, what they called snowball approach to this. They knew of a couple people who were HIV positive, who were gay and who were eager to reach some of their colleagues. And they said, can you identify a few of the people you know who might need this outreach? And just by word of mouth, spread where services were available, what services were available, what behaviors were most at risk, where to find condoms and where to try to reduce risky behaviors among that population group. And that program continued until that anti-gay law was passed in 2014. So for a full decade, that under the radar approach to dealing with men who have sex with men in Uganda actually reached hundreds, if not thousands of people who benefited from that. The clinic that was being used for that was the first one raided when that law was passed, but it didn't go out of business. It's been interesting that they, in the end, realized that some kinds of services were still available. I don't know what this new proposal just in this month might do to that, if it's actually identifying as gay would be outlawed instead of just behaviors. But your questions is very pertinent, and I was pleased that the U.S. government at least did not ignore the problem, but did look at how do we deal with the sensitivities here and try to get the people themselves who are affected, help us in devising a solution to get them into treatment and so on. I hope that answers the question a little bit. Justin, you were there at the time. Does that you?
No, I mean, I wasn't engaged with those populations, to be fair, and so I think it was very tricky and interesting to see how your thoughts on that, because obviously, many people I think who are working in the area would have been highly sympathetic and to these communities, but also not want to put them in the spotlight in working with them. So it's a very, very tricky situation. But I was just there as a student and as a PhD student and researcher, not in any formal diplomatic status.
Gunnar. Vill du pratar du svenska?
Ja, jag pratar svenska.
Okay, we are svenska som hemspråk. I'm married to a Swede. We've always spoken Swedish at home, but happy to have your question in English so everyone can understand.
Yeah, maybe for everyone else's sake. This is a bit of perhaps a strange question, but I've heard you mentioned something in your talk, which I've heard a couple of times before about sort of US positionality on the international arena. Now I've heard it a lot obviously in the world of defense because Afghanistan recently, but essentially I'm sensing that there's a bit of a trend of late, and please do correct me if that's not the case, but I'm sensing that there's a bit of a trend about scaling down in US interventionism in sort of the global scene. And there's obviously in the world of health, we talk about decolonizing and things like that. I'm just wondering about whether there is a trend in the world of health in trying to shift, American attention and funds away from sort of international scene more into sort of domestic settings. I don't know if this.
No, it's a great question. I did put the disclaimer at the beginning of my talk that even though I'm part-time actually at the State Department, the US State Department, still working on global health issues, I'm not speaking for the government, so these opinions will be mine. But I think the phenomenon is correct. I don't think in the Biden administration there is the opposite intention. We are eager to be back as a world leader in global health interventions and leading coalitions. And I think that was Secretary Blinken's motive and the right one in saying we need to get more foreign affairs involvement in the COVID response. This we're not using all of our resources. We're not using our embassies strategically. We're not talking to the right people within other governments about how to make these political and security priorities. So our intention is that we engage fully, but for both of the reasons that you mentioned and one you didn't, we're not. One is that the U.S. leadership in security interventions around the world does not have a good track record in your lifetimes, maybe even mine. The second is that regions are, the absence of the U.S. during the Trump administration meant that others are taking the lead. Germany, certainly in the area of global health. European Union wants a more active role. The African Union set up a CDC, regional institutions in the Americas. Pan American Health Organization is trying to take the lead. ASEAN has set up a global health mechanism. So in every region of the world, there are groups and organizations that see a vacuum and have tried to fill that. And that was motivated in part or a reaction to the Trump administration, which didn't want that leadership role, was talking about America first and saw US resources going to multilateral efforts or are in some way recognizing multilateral leadership as a zero sum with American leadership and didn't want to engage others. We wanted to do it ourselves. And I think in that atmosphere, the ability in the long range of other partners to trust that the US will have the political will to carry out our commitments and our initiatives is rightly in question. And so people are watching their backs and are saying, yes, we're grateful for US involvement and cooperation and financing, but we can't rely on them because they've proven to be unsustainable in recent history. And I think since certainly the relationship with China and with Russia are more adversarial, less opportunity to cooperate, more sense that we're competing even in the global health space. But certainly that isn't leading, health is not a leading factor in the US, Russian or US Chinese competition. But the sense that each region needs to have its own solutions and some of its own supply chain, some of its own sense of organization and preparation is an idea whose time has come, and we're seeing a lot of examples of that. I'm sure some of you are probably writing papers on some of them.
Thanks. And we also have a written question here from Miriam, and I'll just read that out, asking how the civil society, particularly women, led to being involved in global architecture. Sorry, I'm not sure if I got all of that. So women are making 75% of the health workforce, and they're most affected by emergencies. So I think it's a question about the gender divisions in global health architecture and global civil society. Miriam, if you want to clarify on that, please do let us know.
I'll just say it's a great point. And although this session is being led by males, that should not be and isn't typical of many global health discussions. I know that in the offices within the US government, the majority are female-led and the majority of people involved at the table and in the room tend to be women. But that isn't necessarily true all over the world, and it's certainly not true in terms of benefits. The idea that, for instance, community health workers who tend to be women or unpaid or volunteers, caregivers who are 90% women are rarely recognized with financial incentives or compensation. The sense of the clinical trials have not looked at what are the effects on pregnant women, what are the effects on lactating women. There are many areas in which women are invisible to the global health community, and we have to, I think, address these globally, but also one by one in every circumstance to say, who is vulnerable here? Who's providing the services? Are we actually looking at this from a gender perspective? And are we both recognizing the contributions of women, but also anticipating how these could be discriminatory or make women more vulnerable in some of the implementation of the programs? And certainly if it requires people to make visits to clinics, women are much more likely to do that than men, but it also is at the cost of their economic well-being or other responsibilities that they have. So your point is exceptionally well taken, and we're not doing as good a job as we should, but I have to say it is on the table, and in every one of these programs, it seems to me that the US government is asking the question, is there an equity issue for gender? Is there an equity issue for women and young girls? And certainly in the AIDS world, where the disproportionate number of new cases worldwide, not in developed countries, but in Africa, are women and young girls. Why is that happening? What should we be doing about it? How do we get their voices to inform our programs?
Nice. I hope that answers your
And
question.
if you have special advice on that, please don't be shy about offering it, because we really are looking for solutions and we're not there yet.
There's another written question here. Thank you for the presentation, asking what can be done better during the COVID pandemic, both by the WHO and by the US government?
Well, the US government is an easier answer in that we were in denial for a long time. I don't remember at this time exactly this week, 3 years ago, when President Trump said this will be over by Easter and we only have a few dozen cases. Clearly misreading of the evidence. There were many people in the US government, including myself as a kibitzer, and not somebody who even had any responsibility, but who knew that was misreading of what was happening worldwide and what was happening in the United States. So for reasons of anti-science and political short-term advantage, we under-responded, and that cost us hundreds of thousands of lives in the long run. We did start vaccine development, which to his credit was the right thing to do, and I think we were successful about that. In terms of WHO, there was no question there was too much delay in dealing with lack of information from China, not announcing community spread when there was evidence that there was community spread, but the Chinese weren't acknowledging that. Then the question of, actually the WHO was way ahead in the diagnostic, which most countries like the United States didn't adopt, but WHO got an early diagnostic into the field, which was exactly the right thing to do, and may have been one reason that some African countries, for instance, were not early hotspots for the epidemic, because they were testing health workers and others, even though not nearly enough diagnostics for the entire population in affected countries. But WHO also just can't mobilize very fast. They have an emergencies fund, but it was severely underfunded. They ran out of money very early on. And because this was worldwide, because it was a pandemic, national health systems were responsible for the response. When it's in Guinea, Liberia, and Sierra Leone, WHO, at least initially, could surge and use some facilities they have to bring foreign health workers into the countries that needed them most. But within weeks, it was clear that this was affecting every country in the world, and there were no countries that had access capacity to share with those worst affected. And it was developed health systems. It was China, it was Italy, Spain, the United States, UK, where some of the earliest hotspots were. And so these were countries that needed WHO assistance or guidance in particular. But the fact that we were all doing our own thing without much respect for how this was being implemented internationally hurt us. Also, the WHO should have done more about travel bans. All of us were imposing travel bans. After there's a place for those, but it was already too late for those by the time governments like the United States implemented them. And this is in the international health regulations. There's some specific criteria, and WHO wasn't very strong in emphasizing those criteria and reminding countries that they were violating best practice in travel bans. We could go on, but none of us showed up very well in the early days of COVID, and many of the errors have been compounded since.
Yeah. Another question is kind of related, I think, asking why do you believe that countries like the US, which had ranked so high in the Global Health Security Index, did so poorly in the pandemic? And then it continues, what factors in the index was the US ranked or performed highly in, and what factors did the US perform poorly in?
I did try to address that in the slide that showed which factors we addressed poorly, and I don't know if it's worth reprising that slide, but it actually goes into detail on that. Let's just go through very quickly and get down there and try to, because it's important to keep in mind that these weren't unknown factors. Just, why can I not? As always, I'm doing something wrong. Anyhow, the slide, which you can't see, number 21, does say, first, the people who were in charge weren't used to being in charge. They were meeting each other for the first time. We had the wrong structure. We were looking backwards toward how Ebola was handled, something that was not affecting the homeland. We have horrible health equity. The people who were most vulnerable were not getting priority in terms of treatment. That included older people, included people who had to go to essential jobs and so on. We were using our resources for people who were probably at less risk. And things where we did well, there's a good legal structure in the US to be able to declare national emergencies. We had public-private partnerships that worked pretty well. We were certainly aware of the surveillance, the quality of US surveillance, and establishing operation centers and so on to try to share information between national and subnational levels. We did pretty well. But each of those, since when we became a hotspot, each of those became as much a problem as an advantage, because we just weren't prepared in any way for the volume of needs that there were. And when there was this special outbreak in New York, the federal government did not take the measures it should have to have surged resources in the most needed areas. I'm sure we all have examples from our own countries and our own experience of that, but we were learning as we were going, and as I say, unfortunately, our structure in that preparedness index reflected what's going to happen if there's an Ebola outbreak, what if this was SARS, what if this was MERS, in a country that was far away and where the outbreak was relatively isolated, and what would you do to keep it isolated and protect the homeland?
Okay, thank you. We're running out of time, so I think I see the Health Society's hand up, so I might use this opportunity to give them the last question or comment here, given that they are organizing the event tonight.
Thank you, Ambassador Kolker, for sharing with us all of your experience and showing the challenges ahead still on governing global health. My question would be, since COVID showed as well, mostly like the difficulty to collaborate in some settings and some standards. Today, there's talks again namely to review the international health regulation. The WHO leads some of these talks, but without the support for countries as important as the US and China, that raises again strong challenges. And then also the European Union has their own agenda with ERA. So how do you see this as a way to bring the international interest on future preparedness outbreaks? Thank you very much.
Yeah, no, I think that's a great challenge to all of us. And I should say, when I talk to students, I should urge you to look at careers that don't exist yet. When I was 50, it was more than 50 years ago that I finished university, and there was no such thing as a health diplomat or an AIDS diplomat. And those sectors didn't have much overlap, but then suddenly 30 years later, there was a calling for one, and I was the small fish in that pond. So look for opportunities just along the lines of Hugo's question, because health should be an area where we're all on the same side, where the rules should be for the benefit of all of us, and that the expanding the impact of decisions made on behalf of global health would have a clear, measurable outcome that we could take political and diplomatic pleasure in, but we also could actually measure and see what works and try to maximize our impact. And we've instead, I think, seen health as something in which we're looking more inward. What are we going to do to protect our own society from threats that come from somewhere else? And so I think, that frame of mind, the idea that we're all in this together, that this is a security issue, not just a biomedical issue. And it's not just a development issue in which you have aid organizations involved in global health. you need to be involved as a whole of government, and in particular, the political and economic leadership of the government, because every institution has had to make adjustments because of COVID, has realized that our lack of preparedness at every level, in every family, in every community, in every corporation, in every level of government, in every multilateral organization, we simply weren't thinking along the lines of what we would do if a pandemic like this broke out. And now we have to start thinking about that. But it is easy to go back into the cycle of neglect and to say, well, this is almost over. We don't have to be as vigilant as we were a year ago. So so it's not problem number 1 or even number 10. And I think that your question reminds us that there are all sorts of things we can do in our daily lives, in the institutions or the communities in which we're already living, but also to say, well, what do we need in terms of international leadership? Who is in charge? When there's next outbreak, who decides what equality means? What is equity in vaccine distribution? How do we build in incentives so that the private sector will go along with some decisions that are made essentially by politicians to say, you can't just sell to the highest bidder. You need to factor in questions of who would benefit most from these vaccines, question of how those people would get the vaccines, questions of how much that would cost us collectively and you individually as a manufacturer to make these things available to those who should be our mutual highest priority, not because you shouldn't profit from your innovation and invention, but because there really are additional values beyond profit that we value at least equally, if not more highly than this idea of innovative drug development. And so how to build that into a system and how to get someone in charge of political leadership that says, yes, this is how we're going to approach the problem, and then to implement that at all levels so that our economic systems, our ethical systems do prioritize public health values as well as other values that in the default case would take over from those that might have to do with equity or might have to do with health for the people who would most benefit from the intervention. I know that's a pretty vague response, but I think we really have to start thinking in those terms, and the more specific you can be in your own areas where you're working, the better off all of us will be.
I mean, I think in the interest of time, we might want to end it there, but I think that does give a direction of travel. I like how you highlighted that some jobs might not have been invented yet when you started. So for some listening, it may be areas we don't know, but we also recognize, as you say, this need to have collective action towards the common good, if you will, and establish future leaders who are going to take these things forward. So hopefully some of the people on this call listening or on this webinar will be some of those leaders, we hope.
Well, thanks for the honor of being your first speaker in the series, and if I can help in some way in achieving those goals, let me know.
And we really appreciate your time. Thank you so much for joining us. Thank you everyone for joining online. I believe if you're not already members, if you are currently students and you're not already members of the Health Society, do reach out to them to join and take part in their events, and hopefully see you on another talk soon. So for now, I'll just say good night or good afternoon to you all. And thank you very much again.
Thank you.